I'll give you a short little introduction real quick too. Welcome to the Putnam County Library Lunch and Learn. Today we have Scott McKoin. He'll be talking about prostate cancer awareness. Take it away, Scott.
All right, thank you, Spencer. Hello, everybody. My name is Scott McKoin. I have a Bachelor of Science and a nuclear medicine technologist and radiation technologist in nuclear medicine. I have been a technologist for 35 years, the past 24 of them here at Cookeville Regional Medical Center. Really wonderful medical center we have here. I've really enjoyed my career there. During these 35 years, I've seen major changes in the testing, diagnosis, and treatment of prostate cancer. Overview of prostate cancer, I'm going to talk about some facts, signs, symptoms, primary screening tests, secondary screening tests, diagnosis, treatment, and survival rates in prostate cancer. Okay, the prostate is a small gland located down in your groin about the size of a walnut. When you have prostate cancer, that is cancer that develops in the prostate gland from prostate cells that are growing uncontrollably. I want to talk now about some facts with prostate cancer. It's the most common cancer in men here in the United States other than skin cancer. There are roughly 289,000 cases diagnosed every year here in the U.S. Unfortunately, we have 35,000 men die each year from prostate cancer. 1 in 8 men will be diagnosed with prostate cancer sometime in their life, and it almost always is in the later years. 1 in 41 men in the U.S. will die of this disease. However, prostate cancer is nearly 100% survivable if detected early. If you can get early detection and treatment, you will live with prostate cancer, but you will not die from prostate cancer. You will die from, lack of a better word, old age or some other thing. You won't die from the prostate cancer if it's detected early. Your risk for prostate cancer varies based on your age. You can do nothing about that. Your race or ethnicity. If for some reason it has a higher incidence of prostate cancer in men of African ancestry. And 6 in 10 prostate cancers, or 60% of it, are diagnosed in men 65 and older. Prostate cancer is very rare in men under 40. And the average age of diagnosis is 67 years old. If you have a positive family history of cancer of any sort, that is a risk factor, whether it be on your mother or father's side, whether it be basically any type of cancer, but that does increase your risk. There are also inherited genetic mutations, the BRCA1 and BRCA2 gene, breast cancer, ovarian cancer, colorectal, those type of cancers are all increase your risk factor. Okay, slide again. There we go. More on risk factors. Diet, there's been no clear link proven for prostate cancer based on your diet. Obesity, there's no clear link with obesity. Smoking, there's no clear link. We know it's definitely bad for lung cancer and some other cancers it increases, but for prostate cancer, there's no clear link. Chemical exposure, the only things they have found is it being possible some firefighters and some of the unfortunate soldiers that were exposed to Agent Orange during the Vietnam era have a 28% increased incidence of prostate cancer. Inflammation of the prostate, a medical term for that is prostatitis. There's no clear link been established with that causing prostate cancer. Sexually transmitted diseases, there's no clear link and no firm conclusions been found with having a prior sexually transmitted disease. If you've had a vasectomy, it is unclear, research is ongoing, but as of right now, there's been no clear link, but they're still researching that. And prostate cancer is much less common in men of Asian, Hispanic, and Latino descent for some reason. They're researching that, trying to find out why. Other prostate health issues, and these issues may mimic prostate cancer. An enlarged prostate, that's called benign prostate hyperplasia or hypertrophy. That can mimic prostate cancer symptoms. Inflammation of the prostate, prostatitis can mimic prostate symptoms. An overactive bladder can mimic prostate symptoms, and urinary tract infection can mimic prostate symptoms. The true symptoms of prostate cancer: in early stage prostate cancer, unfortunately, does not have any symptoms. Urinary symptoms you may have is a strong urge to urinate immediately, urinate frequently, frequent nighttime urination, pain or burning when urinating, difficult starting your urine stream, or difficulty stopping your urine stream, a weak urine stream, dribbling after finished, or frequent urinary tract infection, or blood in urine. Those are all signs of prostate cancer. They can be signs of other things, but if you have that going on, go see a doctor and get checked out. Sexual symptoms you may have are difficulty having an erection, pain when ejaculating, or you may notice blood in the semen. Those are 3 other signs of prostate cancer. Advanced prostate cancer symptoms. You may have a sudden unexpected weight loss. You may have nagging pain in your back, hips, or pelvic area. The reason for that primarily is that prostate cancer, if it spreads, one of the first places it loves to spread to is bone. So that is one of the reasons you may have back pain or hip pain or pain in your pelvis. This bone pain can be in multiple areas, or it can be in a focal area. You may have pain in your lymph nodes. They may not be swollen, but they may be painful. Shortness of breath, fast heartbeat, fatigue, and dizziness. These can also be signs of advanced prostate cancer. Those usually come about when it has spread not to bone but to soft tissue, and blood in your urine or semen. Diagnosing prostate cancer. We'll talk about 7 things. The first and primary thing most people are familiar with is the digital rectal examination, the DRE. This is performed by your primary care physician or your urologist. It is highly suggested that men have this exam done beginning at age 45. As I said, the risk of developing prostate cancer goes up with age. They think people should start getting checked at 45 years of age. The next one is a PSA. It's a prostate-specific antigen. This is a blood test. They suggest this be done beginning at age 55. There's a newer blood test out now called Prostate Screening Epi-Switch blood test. It is been developed in the past couple of years. The reason it was developed is the older PSA test had so many false positives and people were going for biopsies and things like that. The Epi-Switch is more sensitive. My prostate score, NPS2, is a urine test that is in development at Vanderbilt now, so they don't have to draw blood, where the PSA and the Epi-Switch, you both have to draw blood. With the my prostate score, they can do this with a urine test, but it's not been released on the market yet. Number 5, biopsy of the prostate gland. That's where a physician actually goes in under not general anesthesia, but local anesthesia, and takes a needle and does a core biopsy in the prostate gland to get actual tissue for the pathologist to look at. Number 6 would be complete surgical removal of the prostate gland. And number 7 would be follow-up radiologic imaging. This is a secondary test and it's used to evaluate for the extent of your prostate cancer. or spread. When it spreads from the prostate to other areas like the bone or soft tissue, it's called metastasis. And if you've had your prostate removed, your PSA level will drop down to basically 0, and it should stay there. If the cancer starts to grow again, your PSA level will go up, and that's called biochemical recurrence. Next thing, we want to talk about the accuracy of those prostate screening tests I just mentioned. The digital rectal exam, which is the first line of defense, is very low. It's only a 1 to 10% positivity rate of finding prostate cancer. The PSA blood test is better. It's 55% accurate. The epi switch that I mentioned is 94% accurate. My prostate score that they're doing the research on is 95% accurate. Prostate tissue biopsy is 60 to 70% accurate. The reason it's not 100% accurate is when they go in with that needle to the prostate gland, they may miss the actual cancer and just get healthy tissue. So, but if they do hit the cancer with the needle, then it's 100% accurate. A few years ago, they started developing some MRI procedures, and they're 58 to 91% accurate. Then there's a PSMA, as prostate specific membrane antigen test that we do with a PET CT scanner here at the hospital. It's 98% accurate, and it finds lesions in both bones and soft tissue if it's spread. The nuclear medicine bone scan is the oldest procedure that I've done. It's only about 51% accurate, and it will only find prostate cancer if it's spread to the bone. And then we have CT. Of these last 4 of these imaging modalities, you can see the PET prostate scan is by far the best scan as far as accuracy goes. It shows bone and soft tissue both, where the others just so one will show soft tissue, another one will show bone, but you can get both with one test. Imaging tests in prostate cancer. Talked about the MRI, the CT, the nuclear medicine bone scan, the PET CT, and there's also some places do a transrectal ultrasound. This is a picture of what a bone scan looks like with a person that had prostate cancer. Get that. Person has prostate cancer, you can see these hot spots or lesions in the bone. Over on the right, there's a PSMA PET scan. What we see on it is we can see a hot spot here. This is the PET, this is the CT, this is the fused image. We can see a lesion in the bone here, but we can also see some additional lesions that are in the soft tissue and another one up here in a rib. So that demonstrates, and we have some lesions down here in the abdomen. Some of this is normal, but these those little spots in there are not normal. The reason this has kind of been a sore button for me is, let's say I've been doing prostate bone scans, looking patients for 35 years. We would have a patient come in, have a bone scan. This is an entirely normal bone scan. Nothing stands out, everything looks normal on the bone scan. Yet they come back for a PSMA prostate scan. We do it. We start seeing some lesions down here in the abdomen where it is spread to some lymph nodes outside the prostate. This is an example of one where it has spread into the bone, also into the soft tissue in the chest, and then down here in the abdomen. So the PET PSMA scan is a whole lot better scan than anything available today. I'm not going to spend a lot of time on this, but there's stages of prostate cancer. If you are diagnosed with it, they'll start going, doctors are going to start throwing a lot of numbers and things at you. There's a stage 1, which is localized. All the cancer is still within the prostate gland. It hasn't moved outside. Stage 2 is regional. Your cancer has moved outside the prostate gland, but it's still down in the pelvic area. Stage 3 is when you have distant spread of the prostate cancer. It's moved to a bone or a lymph node or something further off. There's 2 types of staging. There's clinical staging and pathologic staging. Clinical staging are your imaging tests, your PSAs, and the results of a digital rectal exam. Pathologic stage is when they've actually gone in and done a biopsy and gotten some tissue. Excuse me. They're also talk to you about something called a Gleason score. There's a lot of different things on a Gleason score, but don't let that confuse you. You can go in and look it up, and it's just a way to break it down, the score, a little bit further to let the doctor know exactly what he's looking at. Next thing is we have complex staging. On top of all this, they'll be talking about maybe a T1, a T1A, T2, T2B. Those are all different things about the prostate cancer that they may be mentioning to you, and you can go in and look and find out exactly what they mean. They'll tell you whether, how much of the cancer burden you may have. And then we have complex staging. It keeps going on down through the T's, and then they ran out of letters or numbers with the T's, and they went into NX, NO, N1, and then a series of M letters, which lets you know more about the prostate cancer. But if you see those on your diagnosis, you can get more information and find out about it. The age-adjusted PSA scores. Remember I said a PSA was only about 50% accurate. It has false positives and false negatives. About age 40 to 50, your PSA should be 2.5 nanograms per deciliter, somewhere close to that 0 to an upper limit of 2.5. 50 to 60, 2.5 to 3.5 is the normal range. Age 60 to 70 is 3.5 to 4.5, which is where I am. And it's been holding pretty steady, so I'm feeling good about that. And age 70 to 80, 4.5 to 6.8 nanograms per milliliter. After treatment, whether you've had your prostate removed, radiation, or one of the other treatments, your PSA levels should fall to basically 0 and stay basically 0. If they start to creep back up as your physician monitors you, that's called biochemical recurrence. And that's when your physician will probably send you to the imaging department to have some radiological imaging done to help localize where those areas of recurrence are and how they can determine the best way to treat them. Treatment and therapy options for prostate cancer. Some doctors will use a wait and see if your PSA level's off. Keep an eye on that and just monitor it. Prostatectomy, that's the removal of the prostate gland. You may be discussing external beam radiation therapy. That's where they shoot beam radiation onto the prostate gland to kill the cancer cells. Their brachytherapy, that's where they take a small needle and insert radioactive seeds into the prostate gland. That's called brachytherapy. There's cryoablation. That's where they use a freezing gas to freeze the prostate tissue. There's heat treating the prostate, and that's done with a high intensity ultrasound beam. There's hormone therapy to reduce your testosterone level, because elevated testosterone levels or normal testosterone levels, either one, makes the prostate cancer grow. They may do medical therapy. They may give you a drug that blocks your testosterone hormone. You can do a procedure called an orchiectomy. That's where your testicles are removed, and that reduces your testosterone levels. They have chemotherapy agents. These are drugs that will kill the cancer cells. They have immunotherapy coming out now, which are genetically engineered cells they take from your body and re-inject into the bloodstream that help fight cancer. And then they're targeted radioactive drugs. There's one called Xofigo, another one called Pluvicto, and these are theranostic drugs. These are the newest, latest and greatest things coming about for prostate cancer. We do the Xofigo treatments at the hospital. We do not do the Pluvicto treatments. You would have to go to a larger medical center to have that done. I want to thank you, everybody, for having me here to speak about prostate cancer today. And I encourage everybody to please get tested early. One last thing, somebody may be interested. These numbers are not hard or in concrete, but the bone scan at the hospital has a list price of roughly $2,000, but that varies greatly on whether you have Medicare, TennCare, private insurance, that thing, but that just gives you a ballpark figure. And the PET scan is roughly $7,000. And that's really all I have. I hope somebody was able to learn something, and please, if you're a male, go get tested early. Thank you.
Thanks, Scott.
That work?
Yep.